Just one second. I'm just uploading something I found new. Right. Okay, so today who are our coordinators, Dr. Rini?
Ma'am, Vinny and Reshmi from fourth farm D.
No one wants to take over that, is it?
Yes, ma'am.
Okay. Am I allowed to say one sentence about it?
Sure, ma'am.
Unless there is rotation of leadership, we just expect somebody to lead us and we become a flock of sheep and keep following the leaders. If we want to develop our own leadership abilities, then we have to take on that accountability. And at the end of the day, what is it that you have to do? Just be a connection between your class and the rest of us. So it's not like you have to do some hard work or things like that. So really, I'm not very happy that there is no rotation of leadership. Sorry, my camera is just moving all over. Okay. Right. So Vinny and yeah, there's something called Prestig that has become old, and that camera is now not sitting properly on my PC, on my screen. It is just wobbling away, and I don't have the time to get up and change it. Sorry about that. So Vinny and Rashmi, do you just want to recap on what we did last week? What were the things we covered last week, and where did we stop?
Ma'am, we stopped at the part where the doctor was killed.
The doctor was killed. So you remember it.
Yes, ma'am.
Right. Thank you for getting us started on a note where we remember the doctor was killed rather than what the doctor did. Right. We're not supposed to laugh at the doctor getting killed, right? That just doesn't uh, show the right things that we should be doing. But okay, so what did the doctor do and why was he killed? Are you seeing my screen? Are you seeing the screen now?
Yeah, it's perfect, ma.
Thanks, Professor Raman. Thank you. Right. So we spoke about this doctor last week when we were talking about how that big change came about with the decrease in maternal deaths. So we spoke about how this doctor Ignaz, who was in Vienna in the largest maternity hospital in the world, and he noticed that the second wing, which was headed by the midwives, always had about every 25th mother died during birth, during giving birth, whereas in the wing where the doctors and the medical students were there, every 10th mother died. And the reason he could do that is because there was random allocation, not because it was by design, it was by default. Women on alternate days were put to each specific wing. So women coming on day 1, day 3, day 5 would go to wing 1, and women coming on day 2, day 4, day 6 would go to wing 2. So that's how there was random allocation. It was not based on any complications. And when he started noticing that there was this difference between the two wings, within 2 years, he was able to bring about that big change, because he was appointed in 1846, and by 1848, he had reduced pretty much similar on both sides, because every 25th mother was dying now, whether they were on the midwife's wing or in the doctor's wing, because now all his students, they were forced to wash their hands and disinfect their hands before they came into the labor ward, because they would always keep moving between the post-mortem unit where the women who were giving birth were dying because of the sepsis, and which is the infection in the uterus, and they would come back and help the mothers who are delivering. So that was what was causing the problem. And though this came about, he was able to demonstrate that better hygiene and measures of antisepsis is what will reduce the maternal death. It was not accepted. Not accepted because he was not one of the heroes of his times. And therefore, he was put into an asylum. And in 14 days after going to that asylum, he was dead because he was beaten by the guards, and possibly it was by the wounds on his right hand. That is what was told. And one of the reasons why all this happened is because the people who were at the helm of affairs refused to believe what he was telling. Though it was a medical breakthrough, he was ahead of his times. When you're ahead of your times, sometimes this is the price you pay. You pay it with your life. So that's where we had stopped last week. Now, where we are resuming is what is it that has been going on since then, and what have we done with respect to maternal health, and how have we reduced the maternal mortality because we were having the MDG 5 goals. And also towards the end, because Dr. Rini had told me to bring in the therapeutics, I have added the section on what is it that you need to understand about the medicines which need to be available and why these medicines are called as a priority medicine. So that's how I'm going to end it off. So here we are now talking about what is that has been going on since since that time Dr. Ignaz told about these things. It took almost 100 years before people started understanding that what he had told was right, and that could only came about after we started understanding about bacteria, about hand hygiene, etc. And now when you look at in 2017, what is it that is going on? You see from the UNICEF that the share of births attended by skilled health staff, it has been increasing globally. So when we say globally, we are basically talking about low and middle income countries. Now, when this happens, when the share of deliveries are attended by the personnel who are well trained and they have the necessary supervision, and women are getting the necessary care and advice during pregnancy, labor, as well as the postpartum period, that is when you start seeing a big change in the maternal mortality, which started decreasing globally. But even now, you see that we had spoken about the 5 countries in the world where the maternal mortality is the highest. And if you see even now, that's where we are still there, but the numbers are decreasing. So now we are down to about 830 women dying every year. So I wanted us to compare what happened between South Africa and India, because both the countries fall under the low and middle income countries. The difference being up to this point of time, even up to as of now, South Africa has been a higher middle income country and India has been the lower middle income country. And despite the fact that we have so many medical colleges, so many doctors who are passing out every year, we end up losing them because of the brain drain. So either the brain drain happens where we are not finding sufficient doctors in the rural side and they're all in the cities. And if they're in the cities, we're losing, the brain drain is happening from the public sector into the private sector. And on top of it, the brain drain happens from people leaving India to go to other countries the minute either they have qualified or the minute they have sufficient experience to leave the country with. So if you look at 2016 stats, again, this is from UNICEF. What it shows is the number of births attended by the skilled health staff as of 2016. In India, it was only 85.7%, but South Africa was able to push it to 96.7%. So that just 10 to 11% difference makes a massive difference. That is exactly where you are able to reduce the maternal mortality ratio and the maternal mortality rates the minute that birth rate is happening in a healthcare facility where there are people who have been trained in order to make sure that women who are giving birth do not end up with the sepsis in their uterus, and therefore they're not dying from it. So this is one difference I wanted to show. And the second thing I wanted to highlight to you is where the healthcare and nutrition matters for the mother, that is where a whole lot of these things also decrease a lot. And I'm going to connect this point in just a short while when I talk to you about what is happening in the rest of India. And the next point to bear in mind is if the mother dies among several aspects that goes wrong for the children, Education of the children is one of the factors that suffers the most. The next generation of children also end up becoming remaining illiterate, because without the mother around, among all the aspects that this child will suffer with, its education becomes one of the key aspects, because of which the progress is always reduced. So this is something that we have to bear in mind. And the next is, how did the world progress? So even last week I was talking to you about the Millennium Development Goals. So Millennium Development Goals were happening between 2000 to 2015. And what they were trying to do is, in goal 4, they were trying to achieve reduction in child mortality. They wanted to reduce it by 2/3 between 1990 to 2015. And when we talk about that, we are talking about under 5 mortality rate. Now, when we look at goal 5, which is the improving maternal health by 2015, again, they were trying to reduce this by 3/4, which is the maternal mortality ratio. And they were doing it by having indicators. So the good thing that MDGs taught us is, if we know what we are doing, if we know what is it that we want to measure, and if we have indicators to measure them, then it becomes a global tool that can be utilized very well, because these are now standardized tools. So that is how, with the MDG 5, they had several targets for each goal. So target 5.A had 6 indicators. So that is how this has been measured all along. So 5.1 to 5.6, I have listed it out for you. The maternal mortality ratio, proportion of births attended by the skilled health personnel, contraceptive prevalence rate, adolescent birth rate, antenatal care coverage, where at least 1 visit and at least 4 visits after the childbirth, and then unmet need for family planning. So as long as these things are being measured, we knew how it was working out. So it was due to this particular MDG 5 that we saw a huge reduction in India. Otherwise, India was one of 73 countries in the world that was contributing to 90% maternal mortality in the world. And if it is happening in a country like Afghanistan, Iraq, etc., where systems have collapsed completely, it is understandable. But if it is happening in India, where we have numerous medical colleges, not because these are government medical colleges, but because these are private medical colleges. Education has become a business in our country. Despite that, despite the number of doctors that we qualify every year, if so many women are dying in this country because of lack of simple things, we're not talking of any complicated things, these are all preventable deaths, then that is where we have to start looking at what are the other options that we have. What we also have to bear in mind is what is happening with the fragile states which aggravate the maternal deaths. So what is a fragile state index? It is an assessment of 178 countries based on 12 cohesion, economic, social, and political indicators. So different indicators have been taken and 178 countries have been evaluated. And based on that, they are able to tell us how unstable a country is. The minute you have these fragile states, one of the key things that you will see is the increased maternal deaths. So if you remember from last time, let me just show it to you. Last time I had told you about how there is a big difference between Sudan and South Sudan. I don't know if you remember that, right? We had spoken about this maternal mortality ratio, and I had shown you that South Sudan has 789 deaths, and it is the 5th country among the 5 countries where women are most likely to die when they are pregnant and when they are giving birth to children. Whereas Sudan, from which the South Sudan was carved out, has just 311 deaths. The difference is South Sudan is a fragile state. What do we mean by fragile state? There is complete unrest. When there's political unrest and when the healthcare facilities cannot function in that place, one of the major disadvantages will be seen in maternal mortality. So that is the big difference I wanted to point out to you. So Sudan has just 311 women dying every year during childbirth, whereas South Sudan, which is a fragile state, has 789 women dying every year during childbirth. So that was a point that I had to connect for you for the fragile state. The next thing that I wanted to talk to you about is what are the reasons why these women are dying? If we are saying that 830 women are dying every year, despite everything that we know how to prevent deaths, we have medicines to prevent deaths, we have the know-how to say what are the things that are causing the deaths. In spite of that, these women are dying. So we need to know what is it that is causing the death. So now these women are dying as a complication during and following pregnancy and childbirth. So what are these complications? The majority, that account for almost 75% of these deaths, are coming from severe bleeding antepartum. So immediately after the childbirth process has taken place, the bleeding that does not stop, the severe bleeding causes the antepartum and the postpartum hemorrhage, which is the bleeding after the childbirth. And then there is the infections, and usually after the childbirth. The third is the high blood pressure during pregnancy. And the fourth is the complications from the delivery. And the fifth is unsafe abortions. And the reason I had brought about the female feticide last time when I was talking to you about things is one of the reasons for the increased unsafe abortions is the female feticide. The minute in places, especially in India as well, though it is a rule, a law, whatever you want to call it, that the doctor is not supposed to reveal the gender of the child. The minute they get to know it's a girl child, the chances in the rural side is for an unsafe abortion for the mother. So that is also one of the reasons for causing these complications following pregnancy and childbirth. Now, the other reasons why women are dying are because of infections such as malaria and chronic conditions such as cardiac diseases and diabetes. Now, we are talking about, we're not talking about women dying, we're talking about mothers, either during their pregnancy or during their childbirth, who are dying from malaria and chronic diseases such as cardiac diseases and diabetes. Now, I want you to connect this point very, what should I say, where you look at what is it that is causing the burden of diseases in India. With that burden of diseases, how does it affect women? When it affects women, how does it affect their morbidity and mortality when they are pregnant? So that is what I would like you to connect strongly. Because if cardiac diseases are increasing in this country and diabetes is increasing in this country, and the reason for that are the four key driving factors that we spoke about last week. The first one is the huge change in our diet, a diet which is very high in salt, fat, and sugar. Physical activity that has decreased completely. So the sedentary lifestyle, the number of hours that we've spent sitting on a chair, sitting in front of a computer have increased. The level of alcohol and tobacco, the amount that is being used has also increased. So these are the four key driving factors that are pushing our population to have this huge problem with increased cardiac diseases and diabetes and cancers, of course, because all the non-communicable diseases are triggered by these four drivers. But when cardiac diseases start in young women, and even if it is not a cardiac disease, even if it is obesity, for example, during pregnancy, what happens is there is the issues related to high blood pressure during pregnancy. And that becomes a major trigger factor, which puts the woman's health in a different state that she definitely doesn't need during childbirth or after that. So making sure that our body mass index is something that we are alert about, making sure that we are conscious of the four risk factors and ensure that we are not falling prey to succumbing to those eating or smoking and drinking habits and decreased physical activity are extremely important for the next generation mothers. So those of you who are listening to this, make sure that the next generation mothers are aware of the fact that all these are absolutely preventable issues. And if maternal mortality is because of preventable issues, then something is completely wrong with us. If we were living 200 years ago and we didn't understand these things, then it is possibly, it is something that you can forgive. But we can't forgive ourselves if we are completely aware of what is causing these maternal mortality issues and still unable to reduce it. Now, between the years 2000 and 2017, maternal mortality declined by 38%. But as much as we have to give credit to people and to policymakers, to ASHA workers, to ANMs, to all the people who have made it happen, that it has declined by 38% globally. We also have to bear in mind that despite knowing everything, we have only been able to reduce it by 38%. We have not been able to reduce it by a greater percentage. And that, I think, is where we at some point have to take responsibility as healthcare professionals. We can't just point fingers and say, well, it's a doctor's job, or it is the ASHA worker's job, or it is the ANM's job, or it is the government's job. No, it is yours and mine as well. We all have a role to play in this if we don't want to hang our heads in shame when we have women dying from completely preventable conditions. Now, what are the strategies towards ending preventable mortality? So, there have been several strategies. In the last 2 decades, there have been several strategies. So, how has this gone about? One of the first things that comes to mind is the UNICEF. So, UNICEF has this program where they say, how do we end? It is about ending preventable maternal mortality, EPMM program. So, what are their guiding principles? They talk about empowering women, girls, and communities. So, as long as women, girls, and communities are aware of what are the preventable maternal deaths, then it is possible to take personal action, because some of these require personal action. What we eat, how much we eat, how much we keep ourselves physically active, the fact that we don't drink irresponsibly or we don't smoke, these are important. So that is what we mean by empowering women, girls, and communities. And then it's also protect and support the mother and the baby. So that is extremely important. And what you have to also bear in mind is the number of premature births have increased very much. It has increased significantly. And when you talk to neonatologists, that's one of the first things they say. They have no idea why it's happening, but the number of preterm babies are increasing. Babies born in the 7th month, in their 8th month, when they should have been at least for the next 1 or 2 months safe in the mother's uterus before they are ready for birth. The next thing is about the country's ownership, leadership, and supportive legal, regulatory, and financial frameworks. If there are sufficient frameworks to make sure that girls are educated, if there's sufficient, how do you say, there are sufficient spaces to make sure that young women are employed so that there is financial independence. That immediately will translate itself into reducing the number of pregnancies and childbirths that puts the woman under difficult situations. So all of these are equally important. And then to apply a human rights framework to ensure that high quality reproductive, maternal, and newborn healthcare is available, accessible, acceptable to all who need it. So this is where you have to bear in mind that first they started with maternal and child health. And then they went to reproductive, maternal, and newborn child health. And now that has also incorporated adolescent children. The reason is at every point, adolescents were kind of left out in all these policies because they were seen as one of the strongest, because they're the youngest, they are the strongest as well. So reproductive health has come in because if you saw in the MDG as well, I will just take you back to that slide. If you saw even under the MDG, indicator 5.3 spoke about contraceptive prevalence rate, and indicator 5.6 spoke about unmet need for family planning. This is extremely important, and that's the reason they have now added the reproductive, maternal, and newborn child healthcare. And also it is about the cross-cutting actions that needs to be taken. How do we measure these things, as well as improving the data quality, but most important, having effective healthcare financing. Unless there is finances available to make sure that priority medicines are available, we're talking of essential medicines. None of these medicines are patented or medicines that are very difficult to manufacture or are not being manufactured in India, it doesn't fall under any of these groups. And then there are other strategies which speaks to the inequalities in terms of the access to and quality of sexual, reproductive, maternal, and newborn healthcare. And I've always been talking to you about the universal health coverage. UHC is a key word at the moment in the global scenario. Those of you who intend to move from patient care to population care at some point in your career in the next 10 to 15 years, this is a key word that you'll be working towards. You'll be working towards the universal health care, because universal health care, universal health coverage, etc., are being pushed by the World Health Organization. Whatever gets pushed by the World Health Organization, you have to bear in mind that every year in the month of May, all the ministries of health from 193 countries would go to Geneva for a week. And that is where all the resolutions are taken, where the ministers of health and people from the Ministry of Health, they work to, they decide what are the resolutions that they're going to work towards for that particular year in their country. So whatever gets decided there during the World Health Assembly every year in May are how our policies change in our respective countries at a national level. And India is definitely one of the signatories of the United Nations. So India's national health minister is definitely in the World Health Assembly every year. And from there, once the health related things comes at a national level, you have to bear in mind that in India, health is a state subject. So every state has its unique ways in which it can take what are the national priorities, but work on how it needs to implement it at a state level. So Karnataka will have its own ways of functioning when compared to how Tamil Nadu and Kerala would be functioning. So that is why you see the differences between the different states. That is why you generally see Kerala is always a leader in whatever they are doing in the health sector. And Karnataka will be one of the followers, but definitely way ahead of some of the states such as Jharkhand or Chhattisgarh, etc., where you see a huge set of problems coming up, because to a large extent these are new states, developing states, and also to some extent fragile states, where the political scenario and the social unrest creates a lot of issues. And then it comes to how do we take care of the strengthening healthcare systems, and how these healthcare systems respond to the priorities of women and girls, and ensuring accountability. And that goes across the board. Now, one aspect that we have to bear in mind is what the midwives have done with respect to the 73 countdown countries. Just one sec. So these 73 countdown countries were identified as part of the MDG goals. So at a global level in the United Nations, they said that there are 73 countries that account for 90% maternal mortality. And India was definitely one of the 73. South Africa was also one of those 73 countries. And they looked at what are the policies that these countries have. So because they had all these indicators that every country had to measure itself against. What was really annoying is out of 73 countries, only 4 countries had midwife related policies and practices. And that is absolutely unacceptable, because for women to give birth in a space that is safe for them, you really don't need super specialities and you don't need tertiary level hospitals for that. Primary healthcare centers are definitely fine unless there is a complication. And that is when the women have to be referred to the next level of healthcare. But for majority of the women in a rural side, primary healthcare is perfectly fine. If midwives have been trained, if they are regulated, if they are licensed, and if they are supervised, then they are perfectly fine. That program works exceptionally well. And we know all of this. We know all of this. And it would take us so little money to employ these midwives when compared to trying to find one medical doctor for each primary healthcare center in our villages. We know that. And midwives come from the same village. So they have a reason to be there to perform. They're not keen to run away from that place because there is no running water and there is no electricity all the time. But we don't seem to be putting our priorities where it really belongs. So, if there is respectful care in maternity services, that's also another reason why women will come to a healthcare facility to to deliver their baby. Now, this is an interesting one. I've given you the URL where you can find this. This is from the Kanakapura Taluk in India. It talks about the quality of care in pregnancy and delivery. It shows that there's a lack of respect by healthcare providers, and that is one of the reasons why women don't like coming to a healthcare facility to give birth, because they are asked uncomfortable questions. They are denied a birth companion. There is lack of support from the care providers. These were some of the factors that they were talking about. 1 in 4 women reported that their provider revealed personal information they did not want others to know, and that is completely unacceptable. In healthcare, the one and the most important aspect you start with is confidentiality. When we know something about a patient, about a person, that does not need to be known by others, then it has to be respected. This finding was consistent across public, private, basic, and referral hospitals, and that is pathetic. If this is where we are in 2020, it is really pathetic that we are unable to see what is the best way to bring down maternal mortality. We don't need any super specialty, high labor intensive or financially intensive programs. All that we need is make sure we have sufficient midwives, we have training for them, we have regulations for them, we have licensing for them. And that licensing should be based on regular continuing professional development. The minute there's there's constant training that is linked to continuous professional development, and the licensing is linked to that, then obviously there is progression to be seen. But somehow, these things don't seem to take off in our country. So there are 2 books there that I have given the links to. One is the strategies towards the ending preventable maternal mortality, and this other book, which is the World's Midwifery, which is a universal pathway, a woman's right to health. Now, while I'm at this subject still, there is something that I would like if Vinny or Rashmi are able to unmute themselves. Even when I told you the story last week about the hero arrives and what you remembered about the hero, etc. And now when I'm pointing out about the world's midwifery, we are talking from a global perspective, not even just India. And 73 of the 73 countries, only 4 countries having midwife related policies and practices. What is it that strikes you? What is it that you can connect between what happened 2 centuries ago, what is happening now, and what has not changed?
Ma'am, is it that we are not ready to accept change?
We're not ready to accept change. It's pathetic, right?
Yes, ma'am.
We have the evidence. At that point, when we didn't know about bacteria, we didn't know hand hygiene, we were not prepared to accept change. We were ready to send that doctor to the asylum and make sure that he is dead and gone. And now, 2 centuries later, we are still there. Do we call this progress, Vinny?
No, ma'am.
No,
Certainly no.
certainly not. Thank you for that. One other thing I'm looking for, because I gave away the answer. I told you about what is on the right side of my slide. What is it that comes as a connecting point? Rashmi? Okay, Vinny, if you want to go ahead, please do. So not accepting change, yes, that is a generic one. But now specifically, what is the connection that you see between Dr. Ignas? Rashmi, please go ahead. You're raising your hand. So Dr. Rini has to unmute you, I guess. Yeah, Rashmi.
Ma'am, it's the lack of midwives.
Exactly, isn't it? One is lack of midwives. That's what we see here. But what is the connection of the midwives and Dr. Igna's story?
In according, in the section where the midwives were there,
Hmm,
they were lack decreased maternal death rate.
exactly.
Complete. Yes, ma'am.
Exactly. Spot on. Wonderful. Thank you so much. Even 2 centuries ago, where midwives were taking care of the mothers who were delivering children, there was decreased maternal death. Because in the wing where doctors and medical students were taking care, every 10th mother died. But where the midwives were taking care, every 25th mother died, right? So midwives were able to make sure that there was safe delivery even then, when we didn't know what is a bacteria, we didn't know what are antibiotics, we didn't know what is sepsis, we didn't know half the things we know now. So even at that point, midwives were able to do something right, right? Even now, midwives are still able to do something right. But of the 73 countries, only 4 have policies and practices related to midwives. Now, that is the point that Vinny is trying to tell. We are not ready to change. There is something so um, out of place in a human mind that we see all the evidence 200 years later and we are still not ready to change. We are not ready to have policies and practices for midwives. We are not ready to have regulation for midwives. We are not ready to have licensing for midwives. We are not ready to have respectful care and maternity services. Then something is completely wrong with us. All our degrees mean nothing if these basic things we are not able to do. Right, where are we heading now? In 2019, this is our World Health Statistics. Now, this is the statistics for monitoring health for the Sustainable Development Goal. One of the most important documents, and I would really like you to have uh, at least, you should be able to talk 4 or 5 points about a document. So when I show you these documents, I give you the cover page, I give you the URL, there's only one expectation I have of you. Just open that link and read the executive summary. Executive summary is just 1 page, maximum 2 pages in any document. And it should not take you too long to read that. But be aware of this. As a pharmacist, as a PharmD, don't put those horse blinds and go only with medicines. Go with a better understanding of what are the policies that are leading the world. Which of those policies are affecting the way India is monitoring its health? Based on what India is doing at a national level, what are the policies that are happening in Karnataka, where you're studying, to see, how different are we? How are we better than, let's say, Bihar, and where are we better? How do we need to learn lessons from, let's say, Tamil Nadu or Kerala, where they are doing way better than us in Karnataka? So that kind of a learning and understanding comes only when you read these documents. And when I say read these documents, I know that this document will be hundreds of pages. Nobody expects you to read hundreds of pages. Any document you open, you will have an executive summary. You're only expected to read that 1 page or 2 pages of that and have a better understanding. Now, what are these indicators where we are looking at the maternal related issues? First one is, this is about the SDG, right? So SDG 3 is our health and wellness indicator. So 3.1 is, by 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 live births. So that is where we want to bring it down. At the moment, where are we? Who remembers the number? Who remembers at the moment how many deaths are we having per every 100,000 live births? I keep telling you this number. Okay. So if you don't want to recollect, I will tell you it is 830. At the moment, we have 830 deaths for every 100,000 live births. So we want to bring it down to 70 per 100,000 live births by 2030. So we have exactly 10 years to reduce from 830 to 70. And what is going to be challenging is because of a pandemic and the kind of money that every country has lost with the economic related issues, with the constant battering of the system that is going on at the moment, we will be nowhere close to our targets. We have to bear that in mind. So we have to think smart rather than do anything out of this world. If we start employing midwives, if we start employing more ASHA workers, we start employing more ANMs, that is what we need. And by doing that, what do you think is going to be the advantage? When I talk about midwives, ASHA workers, ANMs, what is their gender? Rashmi, Vinny, do you see the point I'm connecting here?
Yes, ma'am.
What is the point,
Yes,
Rashmi?
ma'am. It's generally that to increase the amount of midwives and ASHA workers,
Mhm.
not necessarily like go with the gender.
They are women, right? Because
Yeah.
ASHA workers, ANMs, midwives are women.
Mm.
So the minute you increase the number of posts in every primary healthcare center, every sub-center, instead of having 10 ASHA workers, let's say we have 15 ASHA workers in each primary healthcare center, henceforth. If we make that one change in policy, how is that going to affect us in a good way for all of this?
Will be decreasing the mortality rates.
Okay, that is one direct connection, but what are the other indirect connections? When you increase jobs for women, where are we heading?
Women empowerment.
Yes, that is a packed word. How are we making it happen?
Ma'am,
How do women get empowered?
by giving more opportunities for women,
Yes. So what does it do?
ma'am, it empowers them to do something, stand on their own feet.
Yes. And then what are the other consequences of doing something and being on their own feet? Where does it lead them? Okay, let me give you spoon feeding answers. Would empowered women who have a job, who have job security, who are educated, who are working as midwives, will they agree for female feticide?
No, ma'am.
In their personal lives, will they agree for it?
They'll
No,
not agree for
they will not agree for it. Will they make sure that family planning happens?
it. Yes, ma'am.
Yes. Will they make sure contraception happens? Definitely yes, right. Will they make sure they will have less pregnancies and they will have even lesser abortions?
Yes, ma'am.
Absolutely. That is women empowerment. We should not make it look like women empowerment is some kind of anti-male, a man bashing syndrome. That is when we lose out men. They are 50% of the world's population, and physically they are the stronger of the two genders. So if we lose out the support of men, we are never going to achieve women empowerment. We are never going to achieve maternal mortality ratio decrease. You can only do that when there are enough men supporting this, and that is only possible when there are enough women who are able to be educated, who are able to have their job security, who are able to say family planning is essential. You can't have unplanned children, and you can't have 5 or 6 children because it is impossible with the kind of population that we already have in this country. So it comes down to having 1 or 2 children, and it comes to educating those children. It comes to ensuring the women does not have too many abortions, because contraception is made sure that she doesn't have to go through abortions, go through chances of increased sepsis, go through chances of reproductive problems later on. This is women's empowerment. Am I getting the point across strongly here, Vinny?
Yes, ma'am.
Is there anything you want to add there as a young woman?
Um, no, I guess, ma'am. I think you covered it all.
I wish you had something more to say. All right, say what caught your attention first. You don't have to add anything if it is not coming quickly. What catches your attention first as a young woman?
Ma'am, that in places where there are midwives and like Dr. Ignis found out, like places where there are midwives, it was safer, it was even more um, good over there. But
Yeah,
the places where there are certain facilities available, I don't think it was, the rates were coming out even more increasing in those places.
yeah. So that caught your attention.
Yes,
So
ma'am.
the fact that we need more midwives. Okay. Thanks, Winnie. Right. So these are some of the targets that are being looked into. How now family planning is satisfied with modern methods, how the adolescent birth rate has to decrease. Because at the moment, what is happening is girls aged 10 to 14 years, girls aged 15 to 19 years are delivering children. They are children themselves, and their child marriage is still going on. And in countries where it may not be the child marriage, for example in a country like South Africa, where these are hiv orphan girls, and adolescent birth rate is high there. The reason is because these girls have to put food on the table, or they have to use their bodies to make sure that they can eat something for that day. So that is where the social conditions are a huge problem, and that is where young girls end up becoming mothers, or they end up dying during childbirth because their bodies are not yet ready for childbirth because they are children themselves. So adolescent childbirth has to reduce, adolescent birth rate has to reduce. And informed decision making, women between the ages of 15 and 49, they have to be able to make their own informed decision, whether it is about the sexual relationships, whether it is contraceptive use, or their reproductive health care. This has to start happening, and happening more, so that we have less women dying from pregnancy and childbirth. And the laws that are guaranteed, where women have equal and full access, is important. We need human rights to be driving this, so that we are able to protect our mothers from dying during childbirth and pregnancy. Something I'm very, very, very keen for you to pay attention. Until now, if you were sleeping, wake up now. There's an organization called UN Women, and it talks about women count. I am very keen that young women and men in this group today take it upon themselves to say that one day, 10 years from now, 20 years from now, I would like to work for you and women. I think that's a goal I would like you to have. This gives me goosebumps. I don't know why. I mean, I'm not your age. I had one goal. I had a goal that I should receive a letter in my name from WHO Geneva, and I should go there and work. And that goal was achieved. In 2008, that goal was achieved. But at this point, at 49, I can't start making these new goals of UN women, etc., when I have a huge load of responsibilities, as well as a total disinterest in climbing these ladders any further now. I have no interest in a career where I have to play games to stay in that position and to climb faster and forward. So I would like young men and women who are participating in today's session to say that they would like to start looking at working for UN Women. Because what happens is, when you work in such organizations, the way you can have your outreach across countries increases. It's not about one patient at a time. It is about populations in different countries at a time. And that's where I want you to aim big. Aim big in life. You never know, it will work out someday. If your desire to do it is strong, and you work every single day towards that one desire that you have in your mind, it has to work. It will work. So take a look at what they are doing. 83.3% of legal frameworks that promote, enforce, and monitor gender equality with a focus on violence against women are in place. So to a large extent, there are legal frameworks that is needed. But take a look at the newspaper, whether it is global or Indian, you see what is happening to women and rape cases in women. The adolescent birth rate is 10.7 per thousand population as of 2016, which went down from 11.1 per thousand population in 2015. So there is a slight reduction in the adolescent birth rate. But still, it is not good enough. You can't have 10 out of 1,000 coming from adolescent birth rates. The proportion of women aged 15 to 49 who have their need for family planning satisfied with modern methods in 2008, this document only gave 2008 stats, stood only at 67.2%. And that explains why there are so many unplanned births, there are so many abortions that are going on. The proportion of women aged 20 to 24 years who are married or in union before 18 is 27.3%. So until they are 18, until they become a legal adult, uh, so it's 27.3%. This is the pathetic one. This is for India, right? We are talking about India here. As of February 2019, there are only 12.6% of parliament seats held by women. That is a completely pathetic stats for a country where we have always had women leaders. It's not like we are not sitting in 2020 America, which is yet to have a female president in its history. Whereas we have had women leaders at every level all along, whether they were queens or they were Indira Gandhis or whoever you name it, we have always had women leaders. So it was not a big deal for us. But still, look at our parliament seat, only 12.6% are held by women. And that's completely unacceptable. In 2016, 22% of women aged 15 to 49 reported that they had been subjected to physical or sexual violence by a current or former intimate partner in the previous 12 months. This is something that needs attention. We are talking of 22% of women in that age group. Only 36.8% of indicators needed to monitor the SDGs from a gender perspective are even available. Now that is pathetic. Just 36.8% of indicators which we need to monitor the SDG from a gender perspective are available. There are key gaps in areas such as unpaid care and domestic work, key labor market indicators such as gender pay gap, and skills in information and technology, information and communication technology. So if you take a look at the gender pay gap, I would like young women to go and take a look at this. And next time I will bring this into one of the sessions I'm having, which will be on gender disparity, pay disparity, not just gender disparity. So addressing these gender data gaps is a prerequisite for understanding the situation of women and girls in India and for achieving gender-related SDG commitments. 62 gender-specific SDG indicators in Women Count Data Hub's SDG dashboard are available for 193 UN member states. So we have access to whatever information we need. We just have to keep pushing this forward so women count. All right, this is an important document from the perspective of what's happening at a state level. So there is a 2017 document which says India State Level Disease Burden Initiative. There is an executive summary, and I'm very keen that you take a look at the executive summary. What is it talking about? I've given you the links for that. 1/5 of the world's population lives in India. This is based on the Global Burden of Disease Studies of 2016. Health status is improving, but there are major inequalities between states. And there is rising burden of non-communicable diseases in all states, while infectious and associated diseases are reducing, but still high in many states. There is unacceptably high risk of child and maternal malnutrition. Unsafe water and sanitation is improving, but not enough yet. Household air pollution is improving, but outdoor air pollution is worsening. And cardiovascular diseases and diabetes are shooting through the roofs among all the non-communicable diseases. So take a look at this particular bar graph here, where it shows you what causes the most years of life lost for females as well as for males. So what comes right on top is the ischemic heart disease. After that comes suicide. I want young people to give specific attention to this. Mental health issues are increasing. We can't run away from that factor. COVID is not supporting any of this, but staying resilient, staying hopeful, staying strong cannot be a luxury. It is a necessity, because the very second one, which is causing the most years of life lost among men and women in India, is suicide. The third is stroke, so that is connected to heart disease there. Then COPD. Now comes diarrheal disease, because we were talking of child and maternal related issues. But connected to that is the unsafe water and sanitation. So this is connected to it. I did speak to you about the preterm birth complications. So I did speak to you about how neonatologists are talking about, they don't understand, but there's a significant increase in preterm births in this country. So there are huge complications there. And then road injuries, the way we drive shows up here. Then after that is lower respiratory infections, then diabetes. So this is how heart and heart-related diseases and diabetes are right there on the top. And then comes the rest of the things that are causing our problems. So this is for Karnataka. So this is the Karnataka disease burden profile from 1990 to 2016. And I've given you the link for it. And this is what is happening. So 1990, the life expectancy for women was 62.5 years. And now it has gone up in 2016. It is 71.1 years. For male, it was 59 years in 1990, and now it is 67.1 years. Our life expectancy is going up, but our quality of life is going down, and that is something we have to pay attention to. We may be alive longer, we may be vegetating longer, but if we are not physically fit and we are coming down with heart diseases and diabetes, then that length of life has no value if we can't enjoy that life with productivity and with the zeal that you need for living. So that's something to bear in mind. Again, bringing it back to medicines for maternal health. So this is one of the documents prepared by United Nations Commission on Commodities for Women and Children's Health. This was in 2012. It again talks about excessive bleeding after childbirth and high blood pressure during pregnancy, which are the two leading causes of maternal deaths, but again, can be prevented and significantly reduced when we have policies and maternal health medicines. And the postpartum hemorrhage is the cause of 1 out of every 4 maternal deaths that occur annually. So that is something that really needs attention. And the hypertensive disorders of pregnancy, where the risk factors include obesity, prior hypertension, older age. Now that is something we have to bear in mind. Women, as much as in the rural side, are still, we are looking at adolescent birth and loads of pregnancies even before they are 18 years. In the urban side, where 40% of our population resides, older age of mothers is something we have to bear in mind, because women are delaying marriages for their education to be completed, for them to get good employment before they get into marriage, and then they could possibly delay childbirth even after that. So older age of mother is something we always have to bear in mind. There's a biological clock that keeps ticking. You can't stop that. So there are consequences to that decision as well. And diabetes mellitus. So all these are the high risk factors. So that's something to bear in mind. Now comes 2011. In 2011, what WHO did was they came up with the priority medicines for maternal health. I'm going to show you just now the 2011 document. What they did was there were 27 individual chemical entities and 41 dosage forms and strengths, which gives us the priority list of medicines. Now, what could you do as far as this therapeutics is concerned? One is, of course, be aware of this list. What are those 26 medicines that is forming the priority medicines list? The second thing that you could do is, I've given you this particular web link of the paper that was published by Suzanne Hill. She's from Australia, and right now she heads the Essential Medicines program in WHO. And in 2008, while I was there as a consultant for 3 months, she was also there in the Essential Medicines program, not as a director at that point yet, but now she is there. She has written this paper with two other authors, which talks about a global survey of national essential medicines list, which lists the priority medicines for maternal and child health. Now, you can always do research of this kind during COVID times, where you don't have to necessarily be inside a hospital, you don't have to meet a patient, but research is going on. You're understanding what is research, how to do research, and how to publish a paper. All of those are important skills to develop. Just because there is COVID, life should not come to a standstill, and research should definitely not come to a standstill. So take a look at that paper and see how you can do things based on the essential medicines list. Now, this is the list. Here they're giving priority medicines for maternal and child health. And this came up in 2011 in April, and there is a 2012 list as well. And I've given you the link for that 2012 list as well. Now I'll stop this particular, I want to share the other document. So this is where you have, are you able to see the document here, the WHO web link? Are you able to see this?
Yes, ma'am.
Yes, ma'am.
Yeah, thanks Rashmi and Vinny. Right, okay, I'm going to switch off my video. It's just, okay, so this is the web link where you have, I've given that web link in my slides, and that will be sent across to Dr. Rini for circulation. So this is the web link which talks about priority life-saving medicines for women and children. And this is the 2012 list of medicines, priority life-saving medicines for women and children, downloads. Okay, so it talks about improving lives. So here, let me just increase the size. So this is first for children under 5 years of age, for major causes of mortality and morbidity, child survival. For pneumonia, it talks about amoxicillin, ampicillin, ceftriaxone, gentamicin, oxygen. For diarrhea, ORS and zinc. For malaria, ACT. For neonatal sepsis, it is again the antibiotics that you have here, ampicillin, ceftriaxone, gentamicin, procaine, benzyl penicillin. For HIV, it is the standard first-line antiretroviral therapy. For vitamin A deficiency, it's vitamin A. For palliative care and pain, it's morphine and paracetamol, and vaccines, according to the WHO guidelines. And then these are the priority life-saving medicines for women. And these are for the major causes of sexual and reproductive health-related mortality and morbidity. So for postpartum hemorrhage, and for all of this, they give you the references as well. They don't, it's not just, documents without references. So you have oxytocin, misoprostol. You have this for prevention and for treatment. So under treatment, it is oxytocin, sodium chloride, sodium lactate compound. For the hypertensive problems, we have magnesium sulfate, calcium gluconate injection, and management of severe hypertension, hydrolysin and methyl dopa. For maternal sepsis, it is ampicillin, gentamicin, metronidazole. For provision of safe abortion services and management of incomplete abortion and miscarriage, it is misoprostol and its combination. Then the sexually transmitted infections, it is azithromycin, cefixime, and benzathine benzyl penicillin. For management of preterm birth, it is nifedipine, dexamethasone, betamethasone. And prevention of tetanus in mother and newborn, it's a tetanus vaccine. And for family planning, it is oral contraceptives, injectable contraceptives, implantable contraceptives, and intrauterine devices and barrier methods of contraception. So this particular document also gives you the 37 references that you need. So this is an excellent document for you to start. And again, it's just 3 pages. It's not like you're reading tons of pages. Look for these kind of crucial documents that tells you what is happening globally and what are the steps that are being taken. For example, an estimated 7.6 million children under the age of 5 die every year, and an estimated 1,000 women, most of them in developing countries, die every day due to complications related to pregnancy or childbirth. So this is what the priority life-saving medicines are supposed to be addressing. So with this, I will stop sharing, and if there are any quick points anyone wants to raise, we can have, and then end it by 4:40.
Siddharth wants to ask something. Fourth family.
Okay, Siddharth, please go ahead. Siddharth, have you been able to unmute yourself? Yes, Siddharth.
Okay, ma'am. How much is the ineffective blood transfusion services and the lack of adequate blood banks in the hospitals of India contributed to the maternal mortality rate?
Okay, I definitely don't know the stats to that, but from what you're asking, not having access to blood transfusion and severe bleeding, uncontrolled bleeding after birth, they are absolutely linked. So we know that there will be a problem. So the fact that we don't have reliable units for this is definitely contributing. To what extent it is contributing, Siddharth, I definitely don't know the stats for that. But in a country that has 40% of its people in the rural areas, where they are dependent on sub-centers, not even primary healthcare centers, but sub-centers, and where you know that you don't have doctors in those sub-centers, we definitely can't expect much to be happening there. So from a generic point of view, it is going to be a massive contributor, though we don't know the exact numbers to it.
Okay, thank you, ma'am.
And Siddharth, just coming to that point, are you aware of a program that was to do with the rural physicians that was started in some of the states like Assam and Chhattisgarh?
No, ma'am, I'm not aware of that.
Okay, I will, in one of my next sessions, bring that into my presentation when I'm talking about infant mortality rates and what we need to do to decrease the infant mortality rates. States like Chhattisgarh and Assam, what they did was, with the help of doctors, with the help of medical colleges and doctors teaching these rural physicians, they started a new program which said that, okay, we can't have a doctor. I mean, we don't have doctors who are ready to go to the rural centers. So for the rural centers, we will have these rural physicians who don't study the same number of years as medical doctors have to study, who are given a lot of scholarships, and they come from villages, so they will certainly study and at some point go and serve their own villages. So they started these programs. Ultimately, the Indian Medical Association took them to court and stopped those programs. And that is where you realize how hierarchical can we get in this country, where hierarchy means power and squeezing power away from those who are not in that sector. So it is like, you can't have a rural doctor and an urban doctor. Point taken. But if medical doctors are not ready to go and serve rural areas, what do you want people to do? 60% of India lives in the rural side. So what are those people supposed to do? They can't just overnight arrive in a tertiary center in a city. So even for that, it was not allowed. IMA took this. IMA has the money. Indian Medical Council has the money to spend on lawyers and to spend on court cases and to drag its feet on it. But the people who suffered are people who studied in that program. They had a job. And now, the government is going in all directions because, they're not supposed to be there in the system. So we have all kinds of crazy things happening in this country where 60% of the rural population pays the price for 40% of us who live in cities and enjoy our lives. So at some point, that guilt, that privilege that we enjoy should also give us some guilt, which gives us a reason to say, what is it that I can do, even if it is one drop in that ocean? What is it that I can do as an individual and as a professional to address this particular gap? Even if it means talking, training, whatever we each are good at. We can't suddenly change our professions and can't suddenly change our lives, but we can definitely all contribute to what is happening and what is going wrong in this country. So Siddharth, I hope you take note of what you have asked and see where you will contribute to making things just a little bit better than you find it. Good luck, Siddharth.
Thank you, ma'am.
Thanks. And I really have to congratulate Siddharth for being that first brave young man to finally ask a question. Otherwise, the leadership is conveniently left to young women, and then there is no rotation of leadership. I really hope you all take turns from next week onwards and develop yourselves. It's a wonderful opportunity because you have the safety net. Nobody's evaluating you, nobody's bringing you down. You don't have to prove a point. It's a nice place to be a leader in. So please make use of that opportunity. Dr. Rini, is there anything else, or are we ready to close the session?
We'll wind the session, ma'am.
Okay, fine. All right. Thank you so much, all of you, for attending. I can see there are 64 participants, including myself. So it was really an absolute pleasure to talk to you all about what do we need to do to decrease maternal mortality, and for bringing in the therapeutics part of it that Dr. Rini had asked me to include. So next week, not next week, on Thursday, that is tomorrow, right? Rini, we're having the session tomorrow, right?
Yes, ma'am. Yes, ma'am.
Okay, so tomorrow I'll talk to you about the infant mortality rate and where do we stand in the same lines. All right, thank you so much. Have a good evening, all of you. Bye.
Thank you, ma'am.
Thanks. Bye, Rini.